Good afternoon. Today I would like to introduce you the next pharmacology lecture, drugs acting on cardiovascular system. Drugs having their major action on heart or blood vessels, or those used primarily for cardiovascular disorders, are designated cardiovascular drugs. They can act directly on the cardiovascular structures or through central autonomic nervous system, kidney, autocoins, or hormones which regulate cardiovascular function. Lecture plan: cardiac electrophysiological considerations, cardiac glycosides and drugs used for heart failure, drugs affecting renin-angiotensin system and plasma kinins, and anti-arrhythmic drugs. Let's start from cardiac electrophysiological considerations. The properties which are especially important for understanding drug action on heart are impulse generation, conduction, excitability, and refractory period. First one is impulse generation. Electrophysiologically, two types of myocardial fibers can be distinguished. First, non-automatic fibers, ordinary working myocardial fibers, cannot generate an impulse of their own, and automatic fibers. They are capable of generating their own impulse. Also, two types of action potential are possible: fast channel action potential and slow channel action potential. In here you can see characteristics of fast channel and slow channel action potentials. Conduction. The rate of conduction through a fiber is a function of its membrane responsiveness, which is defined by a rate of rise of action potential as a function of membrane potential at which activation occurs. A more completely polarized membrane depolarizes faster because more sodium channels have recovered voltage-dependent reactivation. This type of relationship is seen in atrial, ventricular, and Purkinje fibers, fast channel fibers which depolarize by sodium current, but not in SA and AV nodal cells, which remain refractory for some time even after attainment of maximal resting potential. Calcium channel reactivation is time-dependent. The sodium channels get progressively inactivated as the resting membrane potential drops. Consequently, less negative the RMP at which activation occurs, fewer are the sodium channels available for activation. Slope of zero phase depolarization, action potential amplitude, and conduction velocity are reduced. A drug which reduces the slope of zero phase at any given resting membrane potential will shift the membrane responsiveness curve to the right and impede conduction. The reverse occurs with the drug that shifts the curve to the left. Membrane responsiveness curve can also be altered by disease. In here you can see membrane responsiveness curve of a myocardial fiber showing the relationship between membrane polarization and delta V delta T of zero phase. Note the depressant action of quinidine, sodium channel blocker. Third one is excitability. This property of a fiber is defined by the strength of stimulus required to elicit a response or to produce an action potential. Hyperpolarization decreases excitability, while small reductions in resting membrane potential increase excitability by respectively increasing and decreasing the gap between it and the threshold potential. Thus, in fast channel fibers, excitability is generally supernormal during the end of phase 3. However, when the resting membrane potential is reduced to a value below the threshold potential, the fiber becomes inexcitable. And fourth, refractory period. Pharmacologically, the effective refractory period, which is the minimum interval between two propagating action potentials, is the most important. It is closely related to the action potential duration. An action potential can be evoked in fast channel fibers even before complete repolarization because sodium channels recover in a voltage-dependent manner about the threshold potential. As such, ERP-APD is less than 1. By contrast, the calcium channels recover in a time-dependent manner progressively after the fiber has fully repolarized. Thus, in slow channel fibers, ERP-APD is more than 1. Most antiarrhythmic drugs increase ERP-APD ratio. Autonomic influences on cardiac electrophysiology and contractility. It would be profitable to recapitulate the influence of sympathetic and parasympathetic stimulation on variables of cardiac function because many cardiovascular drugs have indirect secondary autonomic effects. In here you can see autonomic influences on cardiac electrophysiology and contractility, for example, effects of stimulation of parasympathetic and sympathetic divisions of autonomic nervous system. And in here you can see the principles of pharmacological treatment of main cardiovascular systems pathologies. First of all, it is cardiotonic drugs, which are used for chronic and acute heart failure. Next one is antiarrhythmic drugs, also anti-anginal drugs, drugs for myocardial infarction, and antihypertensive drugs. So we will start from cardiac glycosides and drugs used for heart failure. Heart failure, also known as chronic heart failure, is when the heart is unable to pump sufficiently to maintain blood flow to meet the body needs. Signs and symptoms of heart failure commonly include shortness of breath, excessive tiredness, and leg swelling. The shortness of breath is usually worse with exercise while lying down and may wake the person at night. A limited ability to exercise is also a common feature. Note that chest pain, including angina, doesn't typically occur due to heart failure. In here you can see relationship between feeling pressure and cardiac output in normal and failing heart. For example, this is normal, this is during chronic heart failure, and this diapason is during the increasing doses of digitalis in chronic heart failure. William Withering, English botanist, geologist, chemist, physician, and first systematic investigator of the bioactivity of digitalis, in January 1785 submitted a paper entitled An Account of the Successful Use of Foxglove in Some Drop Size and in Pulmonary Consumption to the College of Physicians in London. In here you can see digitalis purpurea or foxglove. In here, Strophanthus preussii, or wabain, or G. strophanthine. In here, Convallaria myalis. In here, Adonis vernalis. And in here, Nerium oleander. Cardiac glycosides are found in several plants. As you can see in different types of digitalis, in Nerium oleander, Helleborus, Adonis, Convallaria, Strophanthus, and Scilla maritime, and also in toad skin. Classification of drugs used in heart failure. First of all, cardiac glycosides, diuretics, sympathomimetics commonly used in congestive heart failure, angiotensin-converting enzyme inhibitors, ACE inhibitors, angiotensin receptor blockers, renin inhibitors, beta blockers, aldosterone antagonists, and others. Those groups of drugs which are in italics we will discuss today. The others we discussed before in the previous lectures. First of all, cardiac glycosides. The structure of glycoside. The cardiac glycoside consists of an aglycone or genin to which are attached one or more sugar, glucose or digitoxose moieties. The aglycone consists of a cyclopentanoperhydrophenantrene or steroid ring to which is attached a 5 or 6-membered unsaturated lactone ring. Effect of digitalis on Purkinje fibers action potential. The resting membrane potential is progressively decreased to less negative values with increasing doses. Excitability is enhanced at low doses but depressed at toxic doses because sodium channels are inactivated. The rate of zero-phase depolarization is reduced, resulting in slowing of conduction. This action is most marked in AV node and bundle of His. The slope of phase 4 depolarization is increased in Purkinje fibers, ectopic automaticity is enhanced, Latent pacemakers become overt at high doses, producing extrasystoles. High doses of digitalis produce coupled beats by another mechanism. The RMP shows oscillations during phase 4 when their magnitude is sufficient enough, delayed after depolarization's result. The SA and AV node automaticity is reduced at therapeutic concentrations by vagal action, which hyperpolarizes these cells and reduces their phase 4 slope. Toxic doses markedly reduce RMP of SA nodal cells by direct action and stop impulse generation. The action potential duration is reduced primarily at phase 2, and the amplitude of action potential is diminished. Mechanism of action of cardioglycosides. Sodium-potassium ATPase. Digitalis increases force of cardiac contraction by a direct action independent of innervation. It selectively binds to extracellular phase of the membrane-associated sodium-potassium ATPase of myocardial fibers and inhibits this enzyme. Inhibition of this cation pump results in progressive accumulation of sodium intracellularly. This indirectly results in intracellular calcium accumulation. During depolarization, calcium ions enter the cell, driven by the steep calcium gradient through voltage-sensitive L-type calcium channels. This triggers release of a larger amount of calcium stored in sarcoplasmic reticulum through ryanodine calcium channel 2. Cytosolic calcium increases transiently and triggers contraction by activating troponin C on myofibrils. Sarcoplasmic endoplasmic reticular calcium ATPase 2 is then activated, which pumps calcium back into the sarcoplasmic reticulum. Mechanism of action of cardioglycosides: sodium-calcium exchange transporter or NCX antiporter. A fraction equal to that which entered from outside during depolarization is extruded mainly by 3-sodium, 1-calcium exchange transporter, NCX antiporter, and to lesser extent by sacrolemmal calcium pump, calcium 2 ATPase. During phase 3 of action potential, membrane sodium-potassium ATPase moves 3 intracellular sodium ions for 2 extracellular potassium ions. The slight increase in cytosolic sodium over normal due to partial inhibition of sodium-potassium ATPase by digitalis reduces transmembrane gradient of sodium, which drives the extrusion of calcium. The excess calcium remaining in cytosol is taken up into sarcoplasmic reticulum, which progressively get loaded with more calcium, and subsequent calcium transients are augmented. Hydrophilic lipophilic structure of cardioglycosides. In here you can see general structure of a cardioglycoside molecule. The general structure of a cardioglycoside consists of a steroid molecule attached to a sugar, glycoside, and radical group, which are marked on the picture. The steroid nucleus consists of 5 fused rings to which other functional groups such as methyl, hydroxyl, and aldehyde groups can be attached to influence the overall molecule's biological activity. According to the hydrophilic lipophilic structure of cardioglycosides, they can be classified as lipophilic or nonpolar. Time of half elimination is from 120 to 170 hours. As an example, digitoxin, tablets 0,301 gram or 0,1 milligram. Also relatively polar, time of half elimination from 30 to 50 hours. As an example, digoxin, tablets 0,3025 grams or solution 0.025% in 1 milliliter. Next example, selanide, tablets 0,3025 and solution 0,02% 1 milliliter. And other examples are G-toxin and acetyl-digoxin. And one more group, hydrophilic or polar, time of half elimination is from 12 to 24 hours. As an example, strophantine K, solution 0,025% and 0,05% in 1 milliliter, and corglycone, Solution 0.06% in 1 milliliter. Depending on hydro or lipophilicity, bioavailability through oral route, if possible, varies. Pharmacokinetics of digoxin. The pharmacokinetic features of digoxin are listed in the table in here. Bioavailability of digoxin tablets from different manufacturers may differ. Presence of food in stomach delays absorption of digoxin. The volume of distribution of digoxin is large, 6 to 8 liters kilogram. It is concentrated in the heart, 20 times in plasma, skeletal muscle, liver, and kidney. Digoxin is primarily excreted and changed by the kidney, mainly by glomerular filtration. Rate of excretion is altered parallel to creatinine clearance. Its time of half-elimination is prolonged in elderly patients and in those with renal insufficiency. Dose has to be reduced. Digoxin is a cumulative drug. When maintenance doses are given from the beginning, steady-state levels and full therapeutic effect are attained after 4 to 5 times of half-eliminations, approximately 6-7 days. And in here you can see trade names, doses, and drug forms of digoxin. Clinical and physiological effects of cardiotonic drugs. All of them provide positive inotropic effect, which is clinically positive, negative chronotropic effect, which is clinically positive, negative dromotrophic effect, which is clinically negative because it leads to atrioventricular block, and positive bathymetrophic effect, which is also clinically negative in the treatment of heart failure because it leads to spontaneous generation of contraction impulses. And in here you can see sodium, potassium, calcium ions transport and positive inotropic action of cardiac glycosides. Side effects of cardiac glycosides. Hypokalemia or hypopotassemia, we met with it before. It means decreased serum potassium concentration. Next one, hypokalehystia. It means decreased content of potassium in cells. Please remember this one because it will be very hard for you to find the information about hypokalehystia in other sources of literature. The next, xanthopsia. It means that person sees objects in green and yellow colors. And intestinal spasms. Method of digitalization, which is very important. The initiation of digoxin therapy has been divided into rapid and slow digitalization, followed by the maintenance digoxin dose, and the proposed regimens vary considerably. First is rapid digoxin loading. Rapid intravenous and oral digitalization is often used to control the ventricular response in atrial fibrillation and flutter. However, other drugs may be more effective and/or have a more rapid onset of action in the ventricular response in these arrhythmias. Therefore, rapid digitalization is rarely needed unless alternative drugs are contraindicated or have not been effective. The most rapid way of digitalization is intravenous route. Initial dose from 0.25 to 0.5 milligrams of digoxin is given over several minutes, followed by 0.25 milligrams every 4 to 6 hours for a total of 3 to 4 doses. Intravenous digoxin begins to act in 15 to 30 minutes with a peak effect in 1 to 5 hours. Rapid oral digitalization can be accomplished by giving 0.5 milligrams initially, followed by 0.25 milligrams or 0.5 milligrams every 6 hours for a total of 3 to 4 doses. The total loading dose with digoxin varies from patient to patient, but is usually between 0.75 to 1.5 milligrams with intravenous administration and 1 to 2 milligrams with oral administration. Next one, slow digoxin loading. Slow oral digitalization can be achieved by starting a maintenance dose of 0.125 to 0.25 milligrams daily. A steady state will be achieved after 5 cycles of the drug half-life, which is approximately 7 to 10 days in the average subject. And the third one, maintenance digoxin dosing. For most patients, the maintenance dose of digoxin will be between 0.125 milligrams and 0.25 milligrams daily. The proper daily maintenance dose can be estimated from the product of the total effective loading dose times the percent daily loss. The latter can be estimated from one of the following formulas, where PCR is the plasma creatinine concentration and CCR is the creatinine clearance. You can see them in here. As an example, in a subject with normal renal function, the loading dose will be about 1 milligram, 70% of which is bioavailable, and the percent daily loss is about 35%. Thus, the maintenance dose will be about 0.25 milligrams. However, significant variation in maintenance doses is common and is dependent on many factors, including renal function and concomitant medication use. The next group for today is sympathomimetics used in heart failure. First representative is dopamine. The pharmacodynamic effects of dopamine, an endogenous catecholamine, are complex and mediated through selective activation of specific dopaminergic and adrenergic receptors in a dose-dependent manner. Low-dose dopamine, from 0.5 to 2 micrograms each kilogram minute, induces intrarenal vasodilation, augmented renal blood flow, and inhibition of renal tubular sodium reabsorption through direct stimulation of peripheral dopaminergic receptors DA1 and DA2. Intermediate doses from 3 to 10 micrograms kilogram minute favor beta-1 adrenergic receptor stimulation of the heart and peripheral vasoconstriction due to alpha adrenergic receptor stimulation. At higher doses, more than 10 microgram kilogram minute, an elevated systemic vascular resistance prevails and the salutary effect on renal blood flow is diminished or lost. Dopamine is no longer favored as the first-line agent for use in congestive heart failure, owing to the superior pharmacodynamic properties of dobutamine, and is more properly used as an agent for vasopressor therapy. Studies have not supported the renal sparing effect of low-dose dopamine for patients with incipient or established acute renal failure due to ischemia or nephrotoxicity. Evidence that low-dose dopamine protects renal functions during vigorous diuresis for heart failure associated with renal insufficiency has clinical support and a rationale for its use. Next one is dobutamine. Dobutamine is a catecholamine with beta-1 and beta-2 adrenergic agonist properties, which help improve myocardial contractility. In patients with cardiogenic shock due to decompensated heart failure, dobutamine decreases left ventricular and diastolic pressure and raises blood pressure by increasing cardiac output. In some patients, it can induce hypotension by peripheral vasodilation due to its effect on beta-2 receptors. Several studies show improvement in heart failure symptoms with use of dobutamine at continuous infusion doses of 5 to 7.5 micrograms kilogram minute. There is increased mortality associated with dobutamine, so it should be used only for inpatient management of patients admitted with decompensated systolic heart failure for improvement in diuresis and symptoms. Beta blockers, including carvedilol and metoprolol, are widely used in heart failure patients with left ventricular dysfunction. Carvedilol can mask the inotropic effect of dobutamine more than does metoprolol. Higher doses of dobutamine is not preferred in patients with recent myocardial ischemia, and it can increase myocardial oxygen demand and induce tachycardia. Dobutamine can also be pro-arrhythmic. The half-life of dobutamine is a few minutes, which is an advantage compared to other inotropic agents. And in here you can see other sympathomimetics which are used in heart failure, including dobutamine, dopamine, norepinephrine, milrinone, levosimendan, omecamtiv, and mecarbil. Their mechanism: increase in intracellular calcium concentration and effect on mortality. Next group is diuretic agents. We met with them in the previous lecture, and in here you can see some examples of diuretics which can be used in the treatment of heart failure. To remind you, thiazides and related diuretics and their doses, loop diuretics and also their doses, and potassium-sparing diuretics and combinations. The third part of our lecture is drugs affecting renin-angiotensin system and plasma kinins. Renin-angiotensin system. The renin-angiotensin-aldosterone system is a series of reactions designed to regulate blood pressure. When systolic blood pressure drops to 100 or less, the kidneys release the enzyme renin into the bloodstream. Renin breaks down angiotensinogen, a large protein that circulates in the blood, into fragments. One of the fragments is angiotensin 1. Angiotensin 1, which is relatively inactive, is broken down by angiotensin-converting enzyme, ACE. One part is angiotensin 2, an extremely active hormone. Angiotensin 2 causes the muscle walls of small arteries, arterioles, to contract, followed by an increase in blood pressure. Angiotensin 2 also causes the release of the hormone aldosterone from the adrenal glands and vasopressin, an antidiuretic hormone, from the pituitary gland. Aldosterone and vasopressin stimulate kidney retention of sodium. Aldosterone also stimulates the excretion of potassium by the kidneys. The rise in sodium levels causes water retention, which leads to an increase in blood volume and blood pressure. Chemistry of renin-angiotensin system. The amino acid sequence of the amino terminal of human angiotensinogen is shown. And in here you can see renin-angiotensin system regulation. Prorenin, renin, angiotensinogen, angiotensin 1, angiotensin 2, receptors which are prorenin receptor, AT1 receptor, AT2 receptor, and their connection with blood pressure, sodium balance, inflammation, proliferation, and hypertrophy. And in here you can see renin-angiotensin system regulation of blood pressure. You can see that these factors are stimulating and these are inhibiting the formation of renin in Jg cells. Also, the formation of different types of angiotensins and their actions. And in here you can see renin, and prorenin receptors. Renin is synthesized in juxtaglomerular cells of kidney and in tissues, expressing local renin-angiotensin system as a larger peptide preprorenin. In response to appropriate stimuli, both prorenin and renin are secreted, the former in much larger quantities. The concentration of prorenin in circulation is 5–10-fold higher than that of renin. Till recently, prorenin was considered to be only the inactive precursor of renin, but now it is recognized to be active in its own right. And in here you can see renin-angiotensin system regulation by drugs. We have got main four sites of pharmacological action. For example, aliskiren inhibits renin, and as a result, all the sequence reactions after it. ACE inhibitors inhibit angiotensin-converting enzyme, and as a result, all the sequence reactions after this point. The same concerns ARBs, which are angiotensin receptor blockers, and spironolactone and eplerenone, the last step, which is inhibition of increased sodium and water retention. In simple, direct inhibition, for example, of renin will cause indirect inhibition of all other sequence reactions. The same concerns ACE. Inhibition of angiotensin-converting enzyme will indirectly inhibit all the other sequence reactions. And the inhibition of angiotensin receptors will prevent the actions of angiotensin 2. And usage of spironolactone or eplerenone will inhibit aldosterone secretion, so as a result, decrease increased sodium and water retention. We will start from angiotensin-converting enzyme inhibitors, which are acting on this step, and some examples. benazepril, captopril, enalapril, fosinopril, lisinopril, moixapril, perindopril, quinapril, ramipril, trandolapril. Mechanism of action of ACE inhibitors. Inhibit conversion of angiotensin 1 into angiotensin 2. They have got three classes. First class, lipophilic. Second class, lipophilic prodrugs, which are subdivided into subclass 2A, metabolites eliminated by kidneys, and subclass 2B, metabolites eliminated by liver, and third class, hydrophilic. First class angiotensin converting enzyme inhibitors, lipophilic, captopril, alacepril, fentiapril. Second class, lipophilic prodrugs, subclass 2A, metabolites eliminated by kidneys, enalapril, perindopril, benazepril, quinapril, cilasapril. Subclass 2B, metabolites eliminated by liver, ramipril, fosinopril, spirapril, moixapril. And third class, hydrophilic, lisinopril, libinsapril, ceronapril. In here we can see comparative features of some ACE inhibitors. Captopril, enalapril, lisinopril, fosinopril, perindopril, and ramipril. Their chemical nature, activity status, bioavailability as active form, time to peak action, elimination half-life, mode of excretion, duration of action, and daily dose in milligrams. Indications of ACE inhibitors: high blood pressure or hypertension, coronary artery disease, heart failure, diabetes, certain chronic kidney diseases, heart attacks, scleroderma, and migraines. Side effects of ACE inhibitors: dry cough, increased blood potassium level, hyperkalemia, fatigue, dizziness, headaches, loss of taste. Angiotensin antagonists or angiotensin receptor blockers or ARBs. Candesartan, eprosartan, irbesartan, losartan, olmesartan, telmisartan, and valsartan. Mechanism of action: exert their effect by selectively blocking the angiotensin II type 1 AT1 receptor, thus interfering with the action of angiotensin II on vascular smooth muscle and its adverse cardiovascular remodeling effects. Main indications for use: hypertension, chronic heart failure, myocardial infarction, and diabetic nephropathy. Third group, renin inhibitors. Mechanism of action: inhibit the first and rate-limiting step of the renin-angiotensin-aldosterone system, the conversion of angiotensinogen to angiotensin 1. The drug aliskiren. Aliskiren is effective in lowering blood pressure, but as of 20 April 2012, the United States Food and Drug Administration issued a warning of possible risks when using aliskiren or blood pressure drugs containing aliskiren with ACE inhibitors and angiotensin receptor blockers in patients with diabetes or kidneys impairment. They advised that such drug combinations should not be used in patients with diabetes because of the risk of causing renal impairment, hypotension, and hyperkalemia, and that aliskiren should not be used with ARBs or ACE inhibitors in patients with moderate to severe renal impairment. Aliskiren in combination with hydrochlorothiazide was approved by the Food and Drug Administration in 2008 under the trade name Tecturna aliskiren and hydrochlorothiazide combination once again. Next group is beta-adrenergic blockers. We met with them in the lecture number 5, so I will only stop on those beta blockers that have reduced mortality in heart failure. These are bisoprolol, carvedilol, metoprolol, and nebivolol. And the fourth part of our lecture is antiarrhythmic drugs. Antiarrhythmic drugs. These are drugs used to prevent or treat irregularities of cardiac rhythm. Nearly 3 out of 4 patients of acute myocardial infarction, and about half of those given a general anesthetic, exhibit at least some irregularity of cardiac rhythm. Arrhythmias are the most important cause of sudden cardiac death. However, only few arrhythmias need to be treated with antiarrhythmic drugs. Abnormal automaticity or impaired conduction, or both, underlie cardiac arrhythmias. Ischemia, electrolyte and pH imbalance, mechanical injury, stretching due to heart failure, neurogenic and drug influences, including antiarrhythmic drugs themselves, can cause arrhythmias by altering electrophysiological properties of cardiac fibers. On this and next picture, you can see arrhythmic heart pathology. In here, you can see action potential and main heart conductive ways. And in here, phases of depolarization. The important cardiac arrhythmias: extrasystoles, paroxysmal supraventricular tachycardia, atrial flutter, atrial fibrillation, ventricular tachycardia, torsades de pointes, twisting of points, ventricular fibrillation, and atrioventricular block, first, second, and third degree. Agents used in cardiac arrhythmias. First, sodium channel blockers. Second, beta blockers labeled for use as antiarrhythmic. Third, action potential prolonging agents due to effective refractory period increasing. And fourth, calcium channel blockers. In here you can see Vaughan Williams classes of antiarrhythmic drugs. First class is membrane stabilizing agents, which are subdivided into A, B, and C. Generally, these are sodium channel blockers. For example, A, quinidine, procainamide, and disopyramide, B, lidocaine, mexiletine, and C, propafenone and flecainide. Second class, antiadrenergic drugs, which are beta blockers, propranolol, esmolol, and sotalol. Third class, agents widening action potential, prolonged repolarization and ERP, amiodarone, dronedarone, dofetilide, ibutilide. And fourth, calcium channel blockers, verapamil and diltiazem. Note, class 1A agents also have class 3 property. Propranolol has class 1 action as well. Sotalol has both class 2 and class 3 actions. And in here you can see action region of antiarrhythmic drugs, specifically membrane stabilization action potential prolongation, beta blockers, potassium blockers, and calcium channel blockers. Sodium channel blockers. We partly met with them in lecture 3. Disopyramide, flecainide, lidocaine, mexiletine, procainamide, propafenone, and quinidine sulfate. Action potential prolonging agents. Amiodarone, 400 to 600 milligrams day for a few weeks, followed by 100 to 200 milligrams day oral for maintenance therapy, or 5 milligrams kilogram slow IV over 30-60 minutes. Beta blockers once again, and some examples of them with which we met in the lecture 5. And calcium channel blockers. Amlodipine, clevidipine, diltiazem, felodipine, isradipine, nicardipine, nifedipine, nosoldipine, verapamil. Calcium channel blockers classification: phenylalkylamine derivatives, first generation verapamil, second generation galopamil, benzodiazepine derivatives, first generation diltiazem, phenylalkylamine and benzimidazoles derivatives, miberfadil, and dihydropyridine derivatives, First generation nifedipine, second generation nicardipine, felodipine, benidipine, isardipine, and third generation amlodipine, lazidipine, and lercanidipine. We will meet with calcium channel blockers once again in the next lecture. And the last part of our lecture is examples of MCQs. A patient suffering from chronic cardiac insufficiency was recommended to undergo a prophylactic course of treatment with a cardiological drug from the group of cardiac glycosides that is to be taken enterally. What drug was recommended? So from all options, telmisartan is ARB, captopril is ACE inhibitor. We have got only 3 cardiac glycosides. These two, corglycone and strophantine, are not used enterally, so digoxin remains, which is the correct answer. A 50-year-old patient with chronic cardiac insufficiency and tachyarrhythmia was prescribed a cardiotonic drug. What drug was prescribed? So in here are only 3 cardiotonic drugs, A, B, and C, but those which can be used in cases of chronic cardiac insufficiency and tachyarrhythmia is only one, which is digoxin. A patient who has been suffering from cardiac insufficiency for several months has been taking digoxin on an outpatient basis. At a certain stage of treatment, there appeared symptoms of drug overdose. What phenomenon underlies the development of this complication? Of course, it is material accumulation because digoxin, as we mentioned before, is a kind of cumulative drug. A patient with chronic cardiac insufficiency has been treated with cardiotonic drugs and a thiazide diuretic, but in spite of it, there are still edema and risk of ascites. What medication should be prescribed to amplify diuretic effect of the applied drugs? This MCQ is somewhere between this lecture and previous lecture, and as you remember, we may use spironolactone in this kind of cases to amplify diuretic effect of drugs. A patient takes digoxin for treatment of cardiac insufficiency. What diuretic may increase digoxin toxicity due to the intensified excretion of potassium ions? Also one more MCQ somewhere between this and previous lecture, and if you remember, this drug will be from the options hydrochlorothiazide as the one which can increase excretion of potassium ions. A patient that entered the admission office had the following signs of acute cardiac insufficiency: paleness, acrocyanosis, frequent shallow respiration. What drug is indicated in this case? So in this case, we need a kind of cardiotonic drug which can be injected parenterally. From all the options, the only option is corglycone. Thank you for the attention.